Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, our podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is going to bring curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, and leadership from around the world. I'm one of your hosts, Dr. Megan Doherty. And today I'm joined by Dr. Ximena Garcia, a pediatrician and palliative care physician, leader, champion, and pioneer, originally from Colombia. So let's get started. Ximena, welcome to the show. Can you tell our listeners a bit more about yourself?
Thank you, Megan. It's an honor and pleasure to be here today and be able to share my experience. My name is Ximena Garcia Quintero. I am a pediatrician and a palliative care physician trained in Colombia, South America. And now I'm the program coordinator of the San Jude Global Palliative Care Program.
Thank you. We're so glad you're with us. And your work in Colombia is very interesting. I think a lot of people would love to hear more, and that's why we brought you on the show today. How did you develop this program that you developed? I know you started in 2017. Can you tell us about how the program at your hospital developed in Colombia? What type of hospital were you working at?
So Fundación Valle de Lili is one of the biggest hospitals of the country. It's a general hospital, a teaching hospital also. We started in a partnership with the palliative care program that was mostly based to the adult patient. So the director at that moment was Dr. Carlos Chavarro, and he was very supportive with this idea. Why we had this idea is because since I was a pediatric resident, I identified a gap that we need to fill in terms of improving pain management and end-of-life care for children. I identified a tendency for the pediatricians to avoid those type of challenging situations, and that made me think that we need to do it different. And that's how the idea of the pediatric palliative care program started.
And in that adult or that primarily adult palliative care department, how many children were being seen? Because there were a few.
Yes, so 30% of the patients of the whole hospital are pediatrics. And when we went back with Dr. Carlos Chavarro to review the data of the program, we saw that less than 4% of the patients of the program were children. So we said we need to do it better because at least 10% of the palliative care program should be children. That's according to the data that we had for the whole hospital. As soon as we start the program, we fast moved to 30% of the whole palliative care program were children.
That's great. So you came up and matched that number within the whole hospital. And how was the hospital when you brought forward this idea of really expanding and enhancing the pediatric palliative care? What was their response? Were they supportive?
Yes, I think that is one of the key to implement a pediatric palliative care program is to have the support of the medical board. So I think the key was also the adults because they really opened the door to have this special pediatric palliative care program as a broader program that already exists. And they help us advocate with the medical board on the needs and the importance of this program. And it was one of the key person also was Dr. Jorge Madriñal, who immediately support for me to get more training and to establish this specific pediatric palliative care program and make sure that the rest of the pediatric services know about it so we can keep going.
Amazing. And they were able to support you. You went and did some additional training. What training did you do?
So Colombia don't have a formal fellowship in pediatric palliative care. There's fellowship in palliative care, and it's mainly for adult physicians, internal medicine, anesthesiologists. So I did a master's in pediatric palliative care in Spain, but I also did another trainings like EPIC pediatrics training and course that really enjoyed that was PSEP, that means Practices and Education in Palliative Care in Harvard University. And I went to different hospitals in the United States and Spain to see and evidence how they do palliative care there. So I could have this train and start our program in Colombia.
And that's such a wise way to go forward. Taking all those people's experiences, different programs, then you could bring it together as like the program that you your hospital needed.
I think that's a key. That's a key, the collaboration between, we can say, high income countries and low income countries, a lot of resources and scarce resources to learn from each other and build these type of programs that are so needed everywhere.
And what about the funding? That's always such a challenge when you want a new program. Did the hospital give you funding? How did you make it work?
So that will always be a challenge. In countries like Colombia and similar countries, the priorities are usually others. Adults have big volume of patients, and we have, trauma patients and another type of disease that they're always prioritized. So palliative care is usually not one of them. We had support for training, but not to do all the activities that we need to do in terms of education and raise awareness in the community. So we started with box of shoes and we started collecting money with the oncologist, the adult oncologist that was in the same floor of us, or the same floor of the hospital. And we went to each of them like, hey, we're planning to do this activity for the patients that are our families, and we want to take them to the zoo. Can you help us with some money to start this? And they were very supportive. That's how we started. Then we applied for my Chalmers grant, and that really made the difference. We were able to provide a lot of training, more than 1,000 healthcare providers in palliative care, pain management, and end-of-life care and bereavement. Also do other activities and increase the visibility of the importance of palliative care in all levels, in the hospital, but also outside the hospital, and I think in the country and the region.
That grant really had that ripple effect where you were go beyond your hospital, your city. Amazing.
I believe My Child Matters make the difference.
And that's a grant that's available for programs around the world.
Yes, it is available for all hospital, like low middle income countries hospital. Their focus are oncology patients, and the project should be for this type of disease or conditions, but they support like all type of projects in terms of early diagnosis, pain management, palliative care, or decreased neutropenia febrile, or other type of projects.
And how did you get support for having a nurse and a social worker in your program? Did the hospital fund those salaries, or how did it work?
So at the beginning, we had to share resources. We share the nurse with the adult palliative care, the social worker, also, and the psychologist was the psychologist of the oncology, of the pediatric oncology unit. So she follow up the patients for like different reasons of psychology, but also for palliative care. What happened is that in the time they got so involved, inspired with all the magical aspects of palliative care that I think they did more than they really had to. So it was amazing.
And that just speaks to how important that teamwork is in palliative care.
Exactly. It's so much needs and so much to do that it really takes a team to do everything. And at the beginning, we start with these sharing resources, but now the hospital has realized how important this is and how much impact we can make, that they are start supporting exclusive staff for the pediatric palliative. So we started small, but we are getting big with the time.
Yeah, that's amazing. And what about in the beginning? How well was palliative care accepted by the referring pediatric team? Who were your allies?
We have great allies, and I really think that the key at the beginning to find or identify who are your allies in our case was the pediatric oncology unit and the PQ unit, or the pediatric intensive care unit. We were working actually before the start of the pediatric palliative care program, and they allow us to work with them in challenging cases, pain management, end-of-life care. And that's how little by little, all the rest of the pediatric services of the hospital said, okay, maybe we can call them and get some help. And they start referral the patients for pain management, breaking bad news, goals of care, and end-of-life care.
And were there any places where there was resistance or challenges, and how did you work with those?
Oh, yes. I think that's part of palliative care, that type of resistance. We had some resistance, especially from the cardiovascular intensive care unit. At the beginning, neonatal care or NICU, the beginning was a little bit of the resistance, but right away they start referring even more and more patients. And also with bone marrow transplant. And I guess it's because they want to provide all curative treatment And that sense of competition between palliative care and curative treatment was at the beginning part of the resistance, but then with education and raise awareness campaign, that helped us collaborate even more.
Sounds like you did a lot to raise awareness. What are some of the other activities you did to raise awareness?
One of the main activity was we created a workshop that calls MPalpet, which means Essential Messages in Palliative Care and Pain Management. And we designed this workshop as a 5 hours workshop in person. That was before the pandemic. But also we created a tools that they can take after the workshop and integrate palliative care in their daily basis. We create a pain management quick reference guide, a pocket guide, so they can have it all the time, and then a communication skill guide and a booklet where they will have more information about pediatric palliative care if they wanted to do it. We were able to do this workshop with more than 1,000 healthcare providers. We started in the hospital, but then we went out of the walls of our hospital and provide education to other hospitals in the city and the country.
And you train pediatrics, so you kind of have this ability to influence a future generation of pediatricians. How did you train residents, and what have you seen within the residents as they've come up? I know some of them have joined into your program.
Yeah, so it is interesting to see the difference. So I was there. I was a pediatric resident in my hospital, and I didn't hear nothing about palliative care or pediatric palliative care special. But after we started the pediatric palliative care program, the residents were more aware of the importance. And now we have one of the residents that graduated from the hospital. She's an oncologist, and she reached out to me that the hospital that she's right now in Chile want to start a pediatric palliative care program, and she's going to be the leader of that program. Also, we have another resident that graduated from our hospital, is working right now with us in some educational and research project. And also the current leader of the pediatric palliative care program, he was a pediatric resident of the hospital. So we can see how this has been growing with the time.
Tell me about when you first started out your program. What was your vision for it, and how did that evolve and change over the years?
So at the beginning, I was trained outside of the country, right? And I saw very strong programs, hospital-based programs in the United States, and also home care programs in Spain. They are strong on that in hospice and home care. So when I went back to my hospital, I was like, how do we start? And my goal at the beginning was, okay, let's create and implement the best pediatric palliative care program, hospital-based pediatric palliative care program, knowing that there's a huge gap in home care. So that was my main goal. Okay, let's provide the best care when I have the patient here in the hospital. That's what I can control. And then with the time, we will start growing and fill that gap between the hospital and home care. And the current leader of the program, which is Karen, she is building that bridge to make sure that the children's our hospital will keep having the same care at home.
Yeah, and that's so important because many times we know from the hospital they do go home for their care. But it's seeing how you started with a goal of working in one setting, I think that's important.
Yes, I have learned from some leaders in the field that they always say, start small but dream big, and that helped me address. When there's so much need, you get frustrated easy and thinking that you are not doing enough or you're not doing the best. But this type of thinking try to keep me focused on what is my goal and if we are making it or not.
And a lot of what we do in palliative care is empower families, support them. Tell me about some of the really special aspects of the program you created, how it does that.
So in order to grow in palliative care, it's a key to decrease the barriers of the misconception in palliative, because everyone, usually a lot of people, think palliative care as an end-of-life care. So we created awareness campaign, publishing information about pediatric palliative care, misconceptions, myths, and facts in pediatric palliative care in the local newspaper. That's one of the strategies. But also we want to give the message that palliative care is quality of life, not end of life. So we created this annual event that calls Celebrating Life or Celebrando la Vida. vida in Spanish. And we invited all our patients and their families to the zoo of the city. And with the support of the clowns of the hospital, with the group of volunteers, actually the adult palliative care program also went with us, and all of us spent this amazing morning with the families. And that's how little by little we wrote.
And you have a really special story about one of the mothers who was there with you that you shared with me before.
So it was impactful, this story of a young mother that had a baby with a lot of malformations, and she really loved her son. But at the beginning of the day at the zoo, her baby was in the in the carry out, but she didn't want to like bring him out a little bit. But then at the end, the baby was out and shared with all the patients, and very, very internal. She told me that when she saw other children with the same disease and the same characteristic or the same malformation, she felt relieved. Like, okay, my child is not the only one with this, and she felt more comfortable of sharing her son with others.
That's such a powerful story about that mother. Thank you for sharing it. And you also have a special mascot for your program.
Yes. So we wanted to give the message that palliative care is not end of life. And we were thinking, okay, how we do it? And we saw some other examples like Dr. Justin Baker in St. Jude with his koala. So we built this, it is a lion that his name is Brave, or in Spanish, Valiente. So in the first consult with the patient, we gave them this little, how do you say that, stuff?
A stuffed lion.
A stuffed lion.
Toy, soft toy.
A little soft toy. And the children loved it. Even after the pandemic, we made the lion, but with the mask. and that helped us also to encourage them to use the mask. So it was really fun.
Oh, that's such a fun idea. Many times, hospital-based programs, you have to integrate into the intensive care units, and it can be a bit of a challenge. I know they were one of your initial allies and supporters, but tell me about how you really got integrated into their unit.
So I think for everything in life, it takes just one person. Identify that one person that will support you and that will help you. And that was one of the PQ physicians that was very supportive. He identified right away the benefits of integrate palliative care in the children that were in the unit. And every time that he was on ward, he called us to see their patient. And right away, his other colleagues identified or recognized the benefits. And that's how we start getting referrals, even when he was not there. And now with the time, it's every time, almost every day, we have at least 5 or 10 consults from PQ.
And how about with other departments as you first kind of go in and start seeing patients that they've asked you to see? How do you approach that?
So we work hard and equal for every patient. But every time that we got a first referral from a specific service, we got together as a team and said, okay, we got this first referral and we really need to work even harder to make the difference and show them all the benefits that brought palliative care. So we really work hard to show them the difference. So what we did is that every time that we get the referral, I first go and talk with the colleague that was doing the referral and ask, okay, what is the goal for this patient? Do you want us to improve pain, or do you want us to work on goals of care? So we identify why they call us specifically, then we did the intervention and then go back. And the plan for the patient was built with them. So I usually said, I think this patient can benefit from morphine, but what do you think? So I can address also their meat concessions and also clarify what we do. Sometimes it happened that since we are so being associated with end of life exclusively, when we get to, for example, PQ, the nurses were like, oh, why are you here? Why are you seeing that patient? They were surprised that we get that referral. And I have to make it clear, because we are here to improve pain, not because the patient is dying. We are here for other things. That's how, with the time, we grow. I remember some of the leaders also telling me that it takes around 5 years to change the culture of a hospital. And I keep in mind that number. So we keep persistent and patient in the growth of the program.
And you started in 2017, so.
Yes, we started in 17, and in 2019 we got my child marriage grant, and then we had the pandemic that made that everything hard. And then I transferred to United States in 2021. But then there's another pediatrician that is currently the leader of the program who is moving forward this program and with the goals that we established since the beginning.
So really seeing the fruits of now 6 years of all that work that you've done together. Thinking more about the other services, and you really helped them communicate better. And I think also you brought in an element of helping them think outside the box you were sharing.
Yes, I think as soon as they realize all the benefits and including outside the box. So first of all was support in breaking bad news. I think we as a healthcare providers struggle or feeling distress or discomfort on providing breaking bad news and also an end of life care. So that was one of the benefits that I think they saw right away, but also thinking outside the box in terms of symptom management. And palliative care have that. We provide new elements, and I was sharing before, like the use of clonidine and the use of other medication that can help the symptom management. So that was another key element to grow the program.
And what about the initial referrals, and how did they grow over time? And are there any gaps now, areas where you're still thinking we need to really get in and see those kids?
So we start very strong in the oncology, like I mentioned, that those were our allies. But I think the non-oncological disease are a big challenge, not only because of the recognition of the benefits of palliative care to this type of disease, but also because of the health system. So if we have a non-oncological disease patient and we order a follow-up consult, usually the insurance didn't accept it or approve it. So the follow-up of this patient was even more challenging than the oncological. So our numbers is 60% oncological and 40% non-oncological, but I'm pretty sure that will change with the time. One of the gaps right now, I think, is patients with cystic fibrosis and other genetic disease, probably. And like in general terms, non-oncological disease, it's one of the challenge and in our gap that we will fill with.
Yes. Yeah. And you said the referrals grew quite quickly. How did that happen? Why do you think that happened so fast?
So I think we did multiple activities. First is identify that one person that aligned. The other one is to bring new elements to the table, like open outside the box, be always present. One of the in education. During this training, we always said these are the opportunities to integrate palliative care. We can do more if you call us earlier. At the beginning, we have the calls only for, or the referrals only for end of life care, but with the time, we'll start getting referrals for early integration. So with the time, that changed very fast because now they call us for symptom management, breaking bad news, establish goals of care, and even we start perinatal care. And even when we have the diagnosis during pregnancy, we start pediatric palliative care since that moment. And in some cases, we were able to be present during the delivery of the baby and make sure that the goals of care were accomplished.
One challenge that we face when we develop these new programs is just how do we measure the impact, outcomes of palliative care? Tell me about what you did to solve that.
So when I see it retrospectively, I always think to myself, I knew more about palliative improvement and implementation science. So at the beginning, I didn't thought about it. I was like, okay, let's go for it and start the program. But when we had the opportunity to apply for My Child Matters, one of the things that they have is that we need to think how we are going to measure the impact. What are our indicators? And that was a huge challenge for us. I think we as a physician are not trained in that, at least in low middle income countries. But we asked for help in the hospital to other experts in the field, and they help us build our indicators. Another strategy that I learned from other hospitals outside, like in United States, was this satisfaction survey. And I learned this from Boston Children's Hospital. I brought it to my hospital, translated, adapted to our culture and our setting. And that's how we measure the impact. But we also did the satisfaction survey for our colleagues in the hospital to understand how we are really helping them and how they see this new pediatric pediatric palliative care program. And we found out that 90% of the healthcare providers that did the survey found very useful the pediatric palliative care program, especially for pain management and for communication skills. And regarding the families, 80% of the families that we surveyed found that the care of the children improved after the integration of the pediatric palliative care program.
And the families weren't hesitant to do the surveys. Like often we worry it's going to be too much burden on them, asking them to do more things. How was that for them?
Yes, that's a great question, because we have to improve every time. And we try to decide when was the best moment to ask them to do it. And since we have a lot of patients and they have a waiting moment before the consult, that's the time that we were thinking, or we asked them to feel that. But the question was at what time, like how many follow-up consults we should do for them to really realize if we are helping or not. So that it was a number that just came like brainstorming together, and we said at the fourth consult that will make around 4 months later before we start following up, we ask them to do this satisfaction survey.
That sounds like a good strategy there, balancing a few different needs. Thank you, Ximena, so much. Today we've learned so much from you, and I think you've been an inspiration across Latin America and around the world, helping us all understand how we can better develop new programs.
Thank you so much for allowing me to tell you this story. I think nothing should stop us to make our dreams come true.